Today I'll be discussing about the methods of gaining space. Correction of many malocclusions requires space in order to move the teeth into ideal locations. So there are various methods by which space can be created. Okay, so a proper planning of space is important as a part of treatment planning. Now, what is space required for? Space is required for the correction of crowding, retraction of proclined teeth, leveling a deep curve of spee, derotation of anterior teeth, correction of unstable molar relation. How can we gain this space? So the methods of gaining space include proximal stripping, expansion, extraction, molar distalization, uprighting of molars, derotation of posterior teeth, and proclination of anterior teeth. Now coming to the first method, that is proximal stripping. So proximal stripping is a method by which the proximal surfaces of the teeth are sliced in order to reduce the mesodistal width of the teeth. What are the other names of proximal stripping? Is reproximation, slenderization, disking, and proximal slicing. Okay. Usually proximal stripping is done in the lower anterior segment, but it can be done on the upper anteriors and the buccal segments of the upper and lower arches also. Now coming to the indications of proximal stripping. The first one, if the in caries analysis, if the inference shows 0 to 2.5 mm of tooth material excess, then this is an indication for proximal stripping. The next one is Bolton's excess. If there is a mild Bolton's excess in either of the arches, then you can do proximal stripping. The third one, if we broaden the contact areas or contact points of the teeth, this will aid in retention. Hence, proximal stripping is indicated. Next, to maintain a class 1 canine and a class 1 molar relation. Now coming to the contra indications. In case of young patients where there is high pulp chamber, it is contraindicated because there are more chances of pulp exposure while proximal stripping. The next one is high caries index. In patients with high caries index also, proximal stripping is contraindicated. In patients with poor oral hygiene also, it is contraindicated. Now, what are the advantages of proximal stripping? Now, in borderline cases where you can complete the case in a non-extraction pattern, then you can do a proximal stripping. Then to obtain a favorable overjet and overbite, a proximal stripping can be done. And when we broaden the contact points, we can obtain stable results, and hence proximal stripping is preferred. Now I've already spoken about the disadvantages, that is roughened proximal surface. There'll be accumulation of plaque. Then there is more increased caries susceptibility. Then sensitivity will be increased, and improper proximal stripping can lead to alteration of tooth morphology. And because of loss of contact of the teeth, there will be food impaction. Now coming to the diagnostic aids for proximal stripping. First one is arch perimeter analysis. Now after doing a model analysis, caries analysis, if the tooth material excess of 0 to 2.5 mm is there, then this is an indication for proximal stripping. The next one is Bolton's analysis. If there is excess in the Bolton's analysis, the tooth material is excess, then we can reduce the tooth, that is proximal stripping is indicated. Then IOPS, this will give you an idea of the enamel thickness and a rough estimate of the enamel that can be removed from the proximal surface of the teeth without exposing the pulp chamber. Now, how much of proximal stripping can be done? Not more than 50% of the enamel thickness should be removed. Okay, so according to different authors, different amount of tooth material can be removed. So not more than 0.5 mm of tooth material should be removed from a single tooth surface. So according to Sheridan, 0.4 mm reduction per surface of the posterior teeth can be removed, and 0.25 mm in the anterior teeth, thereby gaining a total space of 8.5 mm. Now, how can we do this proximal stripping? What armamentarium required? That is, metallic abrasive strips can be used, safe-sided carborundum discs, and long, thin, tapered Fisher burr. So the first one is interproximal strips. Okay, these strips are usually available at 0.08 mm. They're made of surgical surgical grade stainless steel, okay, in which the diamonds are electrolytically bonded. So what happened? They can be strip holders available to hold these strips. Okay, they can be single-sided or double-sided. Okay, this perforated strips are available, and they also allow optimal visibility and minimal clogging. Now, what are these diamond discs? So diamond discs come in different sizes, and that is coarse, medium, and fine. Okay, so in order to prevent any injury to the lip disc guards should be used. Okay, and the next one is carbide burrs or diamond burrs. So these diamond burrs usually should be used carefully because you can alter the morphology of the tooth. Okay, the next one is leaf gauges. So leaf gauges, they usually measurements that are used. They used to measure the amount of tooth structure needed. Okay, so it's very difficult to measure the thickness that we have reduced. That is proximal stripping that we've done. We cannot measure in millimeters. We cannot measure it. So these gauges will help to measure the amount of tooth material that has been removed. So, and they are available in different sizes. That is 0.1 mm, 0.2 mm, 0.25 mm, 0.3 mm, 0.4 mm, and 0.5 mm. Now, after proximal stripping, we have to do a fluoride application. That is to prevent the caries susceptibility. Okay, since the surface is rough, the caries susceptibility will be increased. So we have to ensure that the fluoride application is done. This next method of gaining space is expansion. Okay, so this is one of the non-invasive methods of gaining space. Usually this is done in constricted maxillary arch or in patients with unilateral or bilateral crossbite. So expansion can be divided into two, that is slow expansion and rapid expansion. Okay, slow expansion brings about dentoalveolar changes, and skeletal expansion, that is rapid maxillary expansion, will bring about skeletal changes. Okay, so the rapid maxillary expansion can be brought about by RME, rapid maxillary expander, whereas the slow expansion is brought about by removable appliances incorporating coffin springs and small expansion screws. The third method of gaining space is extraction. Okay, so one of the most frequently used method for gaining space in orthodontics is extraction. Okay, and extraction that is undertaken as a part of orthodontic treatment is known as therapeutic extractions. Usually the premolars are extracted as a part of orthodontic treatment. Now, extraction of one premolar from each quadrant will give you enough space to correct the crowding or proclination without hampering the function and aesthetics. Okay, so it is uncommon to extract the molars or the lower incisors, but in some cases we have to if the teeth are periodontally weak. Okay, usually the canines, extraction of canines are usually contraindicated, but in cases of horizontally impacted canines, we have to do a extraction, a removal of that canine. Okay. The next one is distalization. Okay, so distalization is moving the molars in a distal direction so as to gain space. Now, distalization of maxillary molars assumes significant value in the treatment of mild to moderate class 2 molar relation. Thus, in these cases, distalizing the molars can be done without extraction. So, the ideal time for distalization is during the mixed dentition period before the eruption of the second permanent molar. Now, distalization can be brought about by the following methods, that is extraoral methods and intraoral methods. Extraoral methods. Headgears derive anchorage from the cervical or the cranial region used to distalize the molars. Now, headgear consists of a face bow and a head strap. The face bow is made up of outer bow and an inner bow. The outer bow is attached to the extraoral head cap or the neck strap, and the inner bow to the buccal tubes present on the molars. Now, what are the disadvantages of using a headgear? One is patient cooperation is essential to wear the appliance. The second one, if it is not worn continuously, and then intermittent in action, okay, so that the results will not be achieved. So this is the picture of the headgear, occipital headgear and a cervical headgear. Now, what are the intraoral methods of distalization? To overcome the drawbacks of the extraoral appliances, various intraoral appliances were introduced. That is sagittal appliance. Then this is a sagittal appliance used for distalization. Then distalization using oral magnets. pendulum appliances. Then modification of pendulum appliances are there. Okay, that is Hilger's Pendex, Hilger's PhD appliance. Okay, or then T-Rex appliance. All these, they use the same mechanism. They have a palatal nance button where the anchorage is derived from the palate. Okay, and the distalization portion will be in the posterior, wherever you want to distalize. Now this is the picture of a repelling magnet used for distalization. A and B are two portions where the repelling magnets are there. This is the distal jet appliance used for distalization. The next is a transpalatal arch. Okay, this transpalatal arch, by placing a rotation in one of the arms, that is shown in the first picture, this arm is now activated, and when this is engaged onto the molar, it will bring about a distal force. Okay, this is also a picture of a molar distalizing appliance. The coil springs are used to distalize. The next is the uprighting of molars. Usually, premature loss of the deciduous teeth, okay, that is the second molars, or extraction of the second premolar, can cause the tipping of the first molar more mesially. Okay, so mesially tipped molar will occupy more space when compared to that of an upright molar. So by uprighting these tipped molars, some amount of space can be recovered. Okay, so this can be done by using molar uprighting springs or some sort of space regainers. Next is derotation of posterior teeth. Okay, next method of gaining space, that is rotation of posterior teeth, will occupy space in the dental arch than normally placed posterior teeth. So derotation of these teeth create more space in the arch. Okay, so this is achieved by using fixed appliances. Okay, that is a couple is used during a fixed appliance therapy, where two elastics are placed in the opposite and parallel direction, where the correction of rotation of the posterior teeth. Now the last one is a proclination of anterior teeth. A proclination of retroclined teeth results in an increase in arch length. Okay, so this is indicated in patients where the anteriors are retroclined. Okay, that is in a class 2 division 2 cases. So this will not affect the soft tissue profile of the patient. Thank you.